Dr. Vijayakumar for this wonderful opportunity given to me to share my views, especially in this program. Also thank the chairperson for this introduction. My disclosures, what I am going to do for another 20 minutes, contents of a top line includes introduction, DPP for inhibitor based case study and case study on usage of SH2 inhibitors. So type 2 diabetes is a multi-concept heterogeneous and progressive cardiometabolic condition. It's an important key message. Progressive nature of type 2 diabetes is one of the major challenges. And incretin therapy offers an alternative option. If you look at the newly detected patients with the type 2, they have limited levels of DPP4 enzyme, both in the fasting and an exaggerated responses in the postprandial period. So there's a definite role for DPP4 inhibitors for managing hyperglycemia. And this particular gene polymorphism in Indian patients, commonly observed genetic variation, increase the odds of type 2 diabetes mellitus and has been associated with reduced generation of incretins and is associated with increased susceptibility to diabetic nephropathy. Hominins opted multiple factors contributing to overall hyperglycemia, and it's a logic to support the 8 defects described under hominins opted. There are 11 interlocking pathways ultimately contributing to beta cell damage dysfunction, resulting in downstream hyperglycemia arising from impaired generation of incretin, reduced secretion of insulin, and so on. So the optimal strategy is to use least number of agents that target the mediating pathways of hyperglycemia, use regimen that stabilize hyperglycemia and act synergistically to reduce cardiovascular and other risk factors and preserve the liver. Of course, incretin hormones account for 50 to 70% of insulin secretion after oral glucosilase. Despite the recent advances in type 2 diabetes management, still unmet needs exist. There is a decline in beta cell function, as well as a decline in glycemic control, and of course conventional therapies associated with weight gain and or hypoglycemia. So incretin based therapies address 6 out of 8 and 7 out of 11, egregious 11. So this particular slide tells you the metformin may stimulate GLP-1 secretion by direct as well as by indirect action. So case 1, this particular patient, businessman, lives with 2 children, diabetic for the past 2 years, weight 68 kg, hypertensive, on medical nutrition therapy, receiving metformin sustained release 500 mg twice daily, atorvastatin 10 mg, as well as telmisartan for hypertension. You can see the patient's current profile with reference to A1C, weight, body mass index, waist circumference, blood pressure, LDL, as well as eGFR. So choosing the second OED after metformin, consideration has to be given on mechanism of action, efficacy, durability. How long will the drug work given the progressive nature of diabetes? And indications, is the class indicated in a broad range of patients? Access, is the class available to most of the patients? So different drugs, Galaxy drugs, they work differently with reference to insulin production, secretion, hepatic glucose output, insulin resistance at the level of liver, peripheral muscles, and so on. And DPP4 inhibitors with reference to insulin production is shown in this slide. And we have the sulfonylureas, gliptins, gliflozin with reference to insulin synthesis, secretion, and its effect on glucagon and hepatic glucose output. So sulfonylurea, it is safe, and we have been using for many long years, and it is usually tolerated nicely, affordable, and convenient therapeutic options. What goes against risk of hypo, weight gain, and beta cell stress? Only gliptins directly benefit the beta cells, increase insulin synthesis, improve insulin secretion, lowers beta cell stress. Only gliptin addresses the alpha cell defect. It has been shown to improve the alpha cell function, that is address the glucagon dysfunction as well as address fasting hyperglycemia. So gliptin efficacy no less than any other conventional oral antidiabetic agents, on par with metformin, sulfonylurea, glitazones, or voglibose. So proven to be as effective as other conventional OADs, and the efficacy quick and durable for years, and more durable than sulfonylurea met combination. Efficacy and durability in patients with type 2 diabetes and CKD, and gliptin with more than 4 years monotherapy data, and useful throughout the age of patients, reductions in A1C, excellent tolerability profile, easy dosing, and low risk of hyperglycemia. With reference to vildagliptin, efficacy is demonstrated in patients more than 75 years of age. And saxagliptin, this particular trial, preservation in combination with the beta cell function across a wide spectrum of the oral antidiabetic drugs. And of course, Leibovitz et al. Demonstrated there was a delayed need of insulin initiation and reduced need of additions up or uptitration of insulin or other oral antidiabetic agents along with saxagliptin. And glycemic parameters influenced by DPP-4 and pooled data on linagliptin showed very good efficacy in terms of reduction of A1C, fasting plasma glucose, postprandial plasma glucose, and improvement in HOMA-B. And these Indian patients, nearly patients were in, the adverse effect similar to placebo in Asians and Japanese, and with reference to the other population age group, DPP-4 work effectively in Asian patients. So, case study, let us come back, diabetic 2 years, weight 66 kg and hypertensive. This patient was prescribed on metformin sustained 500 mg BID, added sitagliptin 100 mg once daily. After 3 months, A1C dropped down to 6.9, LDL, then weight change, and BP remains same. So case study 2, newly detected, weight 70 kg, normotensive, current profile A1C 8.8, and weight 70 kg, already on diet exercise, and patient has been receiving atorvastatin for cholesterol management. And combination therapy, gliptin plus metformin hitting the goal with reference to the insulin production, secretion, hepatic glucose output, and insulin resistance in the periphery as well as in the liver. So DPP-4 inhibitors in combination with metformin may be beneficial for timely intensification of patients uncontrolled on metformin. We know DPP-4 inhibitors address the key underlying defects, and it is associated with the low risk of hypo and weight neutrality, well tolerated with an established safety profile. So when should combination therapy be introduced? According to ADA, ASD, ASC guidelines, after 3 months, if patients are not at target A1C, consider combination therapy. And AAC guidelines recommends if patients are having NT-A1C greater than 7.5, consider combination therapy. So initial combination of Zeta and metformin, significantly more A1C reduction than the monotherapies, and Indian experience with reference to Lina metformin as initial combination, no hypoglycemia, and addition of Lina to metformin did not increase the adverse events. So also combination of Vilda and metformin, significantly more A1C reduction than the monotherapies. So dosing of gliptins with reference to EGFR, and of course we need to modify the dose with reference to vildagliptin, sitagliptin, and saxa, and no dosage modification is needed with reference to Lina. And the dosage modification not based on the risk of toxicity but based on achieving the optimum efficacy with half dose. So our choice of AD in patient with the type 2 comorbidities, take home message. Most of our patients have one or more comorbid conditions, and most of the traditional add-on therapies are either contraindicated or not well suited in such patients. And DPP-4 inhibitors studied to be safe and effective in patients across the spectrum of CKD, and with reference to Zeta, no increased risk of composite of any single type of CV event in patients with established CVD. Next is case 2, newly detected, weight 70 kg. This particular patient, sitagliptin 100 mg and metformin sustainably is 1000 mg once daily. So at the end of 3 months, A1C was brought down to 7.1, LDL 94 mg, weight, waist circumference, EGFR, and BP. So the ideal drugs for type 2 diabetes management, it should be safe, efficacious, well tolerated, and durable with a low risk of hypo and weight neutral or weight loss. So incretin-based therapies, especially DPP-4 inhibitors, come close to this. So it is safe, efficacious across patient population, newly diagnosed, patient on other oral antidiabetic agents, patient on insulin therapy, elderly patients, initial severe hyperglycemia, type 2 with hidden mild moderate renal failure, patients with retinopathy and hepatic insufficiency. So DPP-4 inhibitors are safe and efficacious among almost all group of type 2 diabetic patients. So in short, type 2 diabetes, multiple therapeutic options need to individualize. DPP-4 inhibitors, efficacy similar to conventional and newer oral antidiabetic agents, durable, well tolerated option, addresses multiple pathophysiologies in type 2, use in broad indications including type 2 diabetic patients with comorbidities. Next is with reference to SGLT2 inhibitors. So the kidney plays an important role in glucose homeostasis. Defective renal glucose handling from upregulation, mainly SGLT2, plays a fundamental role in the pathogenesis. So inhibiting the renal reabsorption pathway provides a target for therapeutic intervention. So this case study, diabetic, 3 years, obese, hypertensive, on medical nutrition therapy, rosuvastatin, ramipril. So you can see the patient's current profile: A1C, weight, body mass index, waist circumference, blood pressure, and LDL. So the comprehensive management, SGLT2 inhibitors or DPP4, what to select. So what does the guideline say? Let us look into with reference to DPP4 inhibitors and SGLT2 inhibitors. So no hypoglycemia, no weight gain, and CV safety data. So Indian phenotype. So the characteristic of Indian phenotype, we have the, in spite of low BMI, Indians are having more abdominal fat, more insulin resistant, high levels of C-reactive protein, and low levels of adiponectin, and so on. So the diabetes management beyond glycemic management is essential. So diabetic patients, they are obese, they are hypertensive, and patients with hypertension, most often they are obese as well as they may be having diabetes. So if you look into the ADA Standard of Medical Care 2018, next to metformin, so they have given galaxy of drugs with reference to glycemic control algorithm, American Association of Clinical Endocrinology. When the A1C is greater than 7.5, what next after metformin? You can opt for SGLT2 inhibitors, as well as with reference to triple therapy, SGLT2 next to metformin. So AAC's most recent guidelines has moved SGLT2 inhibitors ahead of DPP4 inhibitors as a first suggested oral add-on therapy. So ACP's, American College of Physicians, most recent guideline update has moved SGLT2 inhibitors ahead of DPP4 first suggested oral add-on. So the combination of metformin plus an SGLT2 inhibitor was superior to metformin plus DPP4 inhibitor. Combination of SGLT2 inhibitor plus metformin favored for weight and systemic blood pressure. That means reduces the body weight significantly, so also blood pressure. So what are the 5 key benefits important lever to treating Indian phenotype? Fast onset of action, and the onset of action commences within a day. Significant and sustained glucose lowering across the diabetes. We can achieve weight loss as well as reduction in systolic blood pressure. Flexibility, insulin independent action, so the risk of hypoglycemia is less, and possible CV renal and other pleiotropic benefits. So dapagliflozin and dapa plus metformin demonstrated A1C reductions of 1.2% or more as an add-on to metformin in patients with a high baseline A1C based on the several trials conducted and articles published in peer-reviewed journals. So adjusted mean change from baseline in A1C at 24 weeks. Very important. A1C reduction with the DAPA is significantly ahead of DPP4 in 24 weeks. Adjusted mean change from baseline in FPG at 24 weeks. Again, DAPA is significantly ahead of DPP4 inhibitors in 24 weeks. And mean change in 2-hour plasma glucose at 24 weeks. Again, DAPA is significantly ahead of DPP4 in 24 weeks. And mean change from baseline in body weight, again, it is significantly ahead of DPP4 in 24 weeks. So with reference to dyslipidemia, there is a favorable effect. It reduces the triglyceride level and changes the consistency of small dense LDL into large beyond, because it reduces body weight, improves insulin sensitivity, reduces fasting postprandial glucose level, reduces the glucotoxicity, thereby activating the lipoprotein lipase activity, and which plays an important role in mobilizing triglyceride and effectively lowers VLDL and other triglyceride and raises the large band LDL. So summary, SGLT2 inhibitors versus DPP4 with reference to A1C, FPG, PPG, body weight, blood pressure. So the green color indicates that this particular agent scores over other, and red color scores less than other.
So sustainability proven over 4 years as an add-on therapy with reference to A1C reduction, body weight. Next is with reference to reduction in the blood pressure and low incidence of hypoglycemia. So SGLT2 can be given across body mass index category. Next is significantly, Indian data on dapagliflozin. You can see very good reduction in A1C, body weight as well as systolic blood pressure. So being watchful can help minimize the risk of adverse events with reference to mycotic infections, urinary tract infections, then euglycemic diabetic ketoacidosis, and kidney safety as well as bone marrow fractures. So SGLT2 modulates several factors related to cardiovascular risk. Next is these are the possible postulated hypotheses and mechanisms of CV effect with reference to SGLT2 inhibitors, in that it modifies certain metabolic parameters as well as induces hemodynamic changes. So the cardiovascular effect of antidiabetes on primary prevention patients remains unknown as yet. According to AD 2017, acknowledge the ongoing CVOT to understand the results in this scenario. So reduction in albuminuria with the dapagliflozin in patients with type 2 diabetes and moderate renal impairment. Very important thing is it reduces the intraglomerular hypertension, number one. Since it inhibits the absorption of sodium glucose from the proximal convoluted tubule, the resulting inflammation and any fibrotic changes in the proximal convoluted tubule, both are very much reduced or minimized. So case study, diabetic 3 years, obese, hypertensive. I have given the profile. So this patient was prescribed dapagliflozin on the top of metformin sustainably 1000 milligram twice daily along with rosuvastatin and ramipril. So at the end of 3 months, there was reduction in A1C, LDL, as well as body mass index and eGFR and blood pressure. So to summarize, so diabetes, obesity and hypertension altogether create a nexus which requires a comprehensive management. Most of the guidelines are also suggesting to focus on comprehensive anti-diabetic management. In glycemic and extra-glycemic parameters, SGLT2 is ahead of DPP-4 inhibitors, and recent guidelines update the SGLT2 ahead of DPP-4 as first suggested oral add-on to metformin, and selecting right patient across BMI category is key to success with the class of SGLT2 inhibitors. So case 4, diabetic, 2.5 years, weight 78 kg, normotensive, on medical nutrition therapy, metformin 500 milligram BID and atorvastatin 20 milligram once daily. So the current profile, A1C 8.4, weight 75 kg, body mass index 26.1, right. Selection of right patient, that is the main key whenever you want to prescribe any particular drug. So SGLT2 inhibitors can be used in patients with type 2 diabetes as an add-on to metformin, sulfonylurea as an add-on to insulin, taking into consideration the contraindications for its use. So can we consider TZDs or sulfonylurea or for this particular patient? What are the effects seen after the administration of TZDs? The pros and the cons with reference to TZDs and sulfonylurea is shown here. Next is with reference to insulin and with reference to GLP-1 receptor agonists. So the GLP receptor agonists, we can achieve weight reduction, significant reduction in A1C, fasting plasma glucose, postprandial plasma glucose, no doubt at all. But it is available as an injectable formulation in contrast to oral formulation. Right. What else do we need to consider before prescribing? Sufficient renal function. There should not be hypotension, dizziness, volume depletion. Patient with recurrent urinary tract infection never prescribed. Check catabolic features, polyuria, and use of fixed dose combination. So dapagliflozin addresses the concerns of Indian phenotype. So with reference to clinical trial data and real world data, and with reference to A1C reduction, weight and systolic BP reduction, it is comparable both in RCTs as well as in real world clinical practice. So dapa-met combination, this particular combination with metformin plus a second agent may allow patients to achieve A1C target faster than sequential therapy. So SGLT2 inhibitors may be used to treat type 2 diabetes at any stage. And patients whose basal insulin regimens fail to provide glucose control may also benefit from the addition of SGLT2 inhibitors. So the treatment guidelines recommend early combination therapy for appropriate patients. So patients with A1C greater than 7.5, we can opt for this particular combination. So therapies with complementary mechanism action must typically be used in combination with the possible benefit of SGLT2 inhibitors in patients with atherosclerotic cardiovascular disease. So complementary mechanisms with the dapagliflozin and metformin address multiple defects in patients with type 2 diabetes. We know the mechanism of action and the site of action of dapagliflozin, and with reference to metformin also, it acts on the peripheral muscles, liver, as well as in the intestine. So together, both the drugs more effectively lower blood glucose without an increased risk of hypoglycemia and weight gain than either drug alone. And combination of MET plus dapagliflozin provides complementary therapy via its unique synergistic mechanism of action. So DAPA and metformin are supported by AAC guidelines, the key therapeutic principles, because glycemic control is a key, and above all, it has a complementary mode of action. So greater benefits in reducing ANC, greater benefits in reducing body weight, and greater mean reduction in blood pressure with no increase in measured orthostatic hypertension and no increase in the heart rate also. That means it may not stimulate the sympathetic nervous system. DAPA plus MET A1C reduction in patient with high baseline A1C, I have already shown this particular slide. If you look into the meta-analysis with reference to dapagliflozin on 21 phase 2B and 3 trials, they have clearly shown the benefit in terms of 3-point MACE. And this particular publication, lower risk of heart failure and death in patient initiated on SGLT2 inhibitors versus other glucose lowering drugs. This CVD real study, multinational retrospective observational study conducted to evaluate the cardiovascular effects of patients on SGLT2 inhibitors compared to patients on other oral glucose lowering drugs. There was significant reduction in cardiac death as well as hospitalization for heart failure and all-cause mortality. So initiation of SGLT2 versus other glucose lowering drug, it was associated with 39% lower incidence of hospitalization for heart failure. Majority, very important thing is majority of patients did not have established CVD. Only 13% of the patients had established CVD, in contrast to EMPA-REG outcome wherein patients, majority of the patients were having established cardiovascular disease. That the benefits of SGLT2 on the prevention of heart failure may extend to lower risk patients than those enrolled in randomized trials so far. So benefits previously reported with EMPA in the context of randomized trial may be applicable to a broad population of patients with the type 2 in real world practice. So the lack of heterogeneity in results across countries despite geographic variations in the use of specific SGLT2 suggests a class effect. So CVD real, Nordic, DAPA compared to DPP4, and this was presented as a poster in European Society of Cardiology, as well as this was presented at the 77th scientific session of the ADA. So metformin extended release, is there any added advantage over the immediate release formulation? Of course, unique technology. And the adherence is very important, and adherence is greater compared to the immediate release formulation because the GI side effects are very less or minimal. So this seems to be more effective than metformin in improving glycometabolic control, lipid profile, and levels of some adiposokines in patients with the type 2 diabetes. So trial was a randomized controlled trial studies was conducted comparing the immediate release versus sustained release formulation, and these significant differences were observed. So to summarize, there continues to be a need to a more proactive early treatment of type 2 diabetes with the optimal agents, and DAPA plus MET combination has complementary mechanism of action to address some multiple defects, and DAPA MET therapy has shown multiple benefits with regard to A1C, blood pressure, and weight sustained for 4 years. So case 4, diabetic, 2.5 years, and weight 78 kg, normotensive. I have given the A1C profile weight. So this patient was given DAPA 10 milligram once daily, metformin sustainedly 1000 milligram once daily. Right. So there was a change in A1C, LDL, and weight. So conclusion. So current therapies have limitations to work through comprehensive management. Recent guidelines update has put SGLT2 ahead of DPP4 as first suggested oral add-on, and dapagliflozin provide good glycemic efficacy fast onset of action with minimal risk of side effects, including hypo, and extra glycemic benefits of weight loss, modulation of blood pressure, may lead to improved patient outcomes, and sustained efficacy and safety has been documented with dapagliflozin. Thank you very much for your kind listening.
Thank you, Dr. Shanmugavelu.